Good evening, everyone. Thank you for joining us for the IDF Forum, Immunoglobulin Replacement Therapy for Individuals with Primary Immunodeficiencies. On behalf of the Immune Deficiency Foundation, welcome. Whether this is the first time you have attended an IDF Forum or you've joined us before, we're honored to have you with us tonight. I'm Kathy Antela, Vice President of Education at the Immune Deficiency Foundation, and I will be your MC tonight. As always, a disclaimer before we start that the information presented during this event is not medical advice, nor is it intended to be a substitute for medical advice, diagnosis, or treatment. Please always seek the advice of a physician or other qualified health provider with questions concerning a medical condition. IDF's mission is improving the diagnosis, treatment, and quality of life of people affected by primary immunodeficiency through fostering a community empowered by advocacy, education, and research. IDF's vision is ensuring that everyone in the US affected by PI has a fully informed understanding of the PI diagnosis that affects them, all available treatment options, the expected standard of care, and all of the opportunities available to them to receive support within the PI community. Well, thank you to our wonderful, wonderful sponsors who make these forums and so many of our other programs available to everybody in the PI community. So thank you to our 2021 sponsors, CSL Behring, Grifols, Takeda, Horizon Therapeutics, Octapharma, Accredo, ADMA Biologics, Bioproducts Laboratory, Farming Healthcare, X4 Pharmaceuticals, Kedrion Biopharma, and Celio Health. Upcoming events. Well, as always, we have virtual Get Connected groups throughout the nation. These are small networking groups for individuals with PI and family members. Get together, meet each other, talk, have fun. They are ongoing throughout the year. And upcoming forums, and you will be receiving invitations to these. One, November 9th, the next one is November 9th, and it is managing stress and anxiety during the holiday season. Not that we have any stress or anxiety during the holiday season, but oh well. Zebra Strong series, we have another series, and the first session of How to Thrive and Survive in an Emergency is scheduled for November 16th. And then many people in the PI community work with the specialty pharmacy. So what's special about a specialty pharmacy? That forum is on November 18th. So we hope that you will join us for, of course, all of them. And now to introduce our presenter this evening, Carla Duff. Ms. Duff is a certified pediatric nurse practitioner at the University of South Florida and Johns Hopkins All Children's Hospital, both located in the Tampa Bay, Florida area. And Ms. Duff is also a member of the IDF Nurse Advisory Committee. So at this time, I would like to welcome Ms. Carla Duff as she presents immunoglobulin replacement therapy for primary immunodeficiency. Carla, take it away.
Thank you so much for having me tonight. And so I've had patients ask me, so there have been people, so I'm just going to say I recently graduated with my doctorate. I defended last Thursday. So I am now officially Dr. Duff, which is weird because I don't say that to my patients and they keep saying to me, didn't you get your doctorate? I'm like, it just doesn't roll off my tongue yet. So anyway, tonight we're going to talk about IG therapy for the PI patient and how one size does not fit all. And some of these slides I'm going to spend a little more time on, and other slides we're going to go through very quickly to stay within the constraints of the time allotted, but you'll be receiving all of the slides. So we're just going to talk about, why do we give you IG therapy? And then mainly I want to discuss the advantages and disadvantages of the different routes, Because recently I've had quite a few patients tell me they didn't even know that they had an option of choice. And I think it's really important that patients realize they have the choice in their therapy. It's a discussion that they should be having with their provider. So I want to make sure you leave here tonight armed with some knowledge so you can have that discussion. So what is immunoglobulin therapy? So it's, it's antibody concentrates. So essentially we're giving you the antibodies you don't make. And we pull that from tens of thousands of donors. So we get all these wonderful donors who give us their plasma so we can make the antibodies that you're not making. So we help them give them to you. And that's why we have patients who don't make a response to the Pneumovax. And then all of a sudden they're on IG therapy and now they have pneumococcal titers. No, they didn't start making them all of a sudden. It's that we're giving them somebody else's. So this is just a history of immunoglobulin replacement. And I actually think I need to update it at the end. I think we're missing, because this slide cuts off after 2010. So then facilitated should be at the very end of this slide. But as you can see, IG therapy has come a long way in all these years that we've been doing it. And we have IV, we have subq, and now we have facilitated subq. So we actually have a lot of options for patients. And the goal is for the patients to have the therapy that fits best in their life. So how are they different from other infusions? Because I was actually at a conference not that long ago, and I had a provider say to me, well, it's just like giving an IV antibiotic. I was like, oh, no, it's not. It's very different. So IG therapy is chronic. This is something patients are going to take usually forever. It's not a short-term fix. This is a lifelong medication. And often being on this medication and having this illness impacts your quality of life. Patients miss days of work at school, you get fatigued, you have infections, and it can affect the economic aspect of your life. So it's important that we realize that this is not just like giving an IV antibiotic for 14 days and then the patient goes back to what they were doing before. This is a lifelong treatment that not only affects the patient, but it also affects the entire family. And we need to keep that in mind. This is not like giving an IV antibiotic. And when you talk to patients about this, I think it's really important as providers, we remember the 5 C's, that it's a chronic care approach. So as patients, the relationship you develop with your provider is often going to be lifelong. So it really needs to be that approach of, I'm going to see you a lot. We're going to become great friends. I'm going to know about your life. You're going to know about mine. So let's make sure we have that chronic care. This is not an emergency room or an urgent care where we're going to see each other once and we're never going to see each other again. And it's very comprehensive treatment. An immune deficiency affects the entire person. It's not like when you go to the GI doc and they only look at your belly. This is a whole person, and we have to look at the whole person. And we're partners. And that's, I think, something really important, and that a lot of patients, we're trying to help patients be better at advocating for yourself. Realize this is a partnership. Your provider alone can't do this. We need to have the input from our patients. We need to know what works for you, what doesn't work for you, and what can we do better, which leads us into the next topic, communication. Talk to each other, write down your questions. A lot of times patients will say, well, I did it because that's what my doctor said, or the nurse told me to do it this way. That blind faith in your provider is wonderful, but if you're not sure of something, ask. If you've heard about a different option, ask. It is always okay as a patient to ask. And then choice. You have a choice in your therapy. You may not have a choice if you get to do therapy, because there are patients who are like, I don't want to do it. I'm like, okay, but you're 5, so you don't really get a choice in whether we're going to do it or not. But as parents and patients and caregivers, there is a choice of what therapy do we want? How do we want to administer it? Do we want to do IV? Do we want to go to an infusion center? Do we want to do it at home? Do we want to do subcutaneous? Do we want to do facilitated subcutaneous? Patients have choices, and it is really, really important that patients are aware of that. So here are your choices. You have IV, you have subcutaneous, and you have facilitated. So what do you need to know to have you help make the best choice? I always tell my patients, this should be your life, and your disease should be a tiny part of it. If this is your disease and we're fitting your life in, we're doing it wrong. We need to make sure we're finding the choice for you that gives you the opportunity to live your best life. So subcutaneous versus intravenous. And when I say subcutaneous, I'm referring to both traditional subcutaneous and facilitated. The biggest difference is you don't need an IV. You don't have to get an IV started. So you don't need to get a port placed. You don't need to have someone poke you multiple times. No IV is needed. Both routes, whether you're using IV or using subcutaneous, they're equally efficacious. Patients tolerate them, and the patients that love their IV and don't want to switch, and the patients who love subcutaneous and they don't want to switch. It's all about finding the route that works best for you. One of the biggest difference is the volume. So subcutaneous, if you're doing facilitated, it's a little different. Traditional subcutaneous, you're doing less volume more frequently. So daily, every 5 days, every 10 days, every week, every 2 weeks, depending on the brand. So you're doing smaller amounts more frequently. But one of the great benefits of that is the amount of systemic side effects is way less. So if you are a patient who's having a lot of reactions with your IVIG and you're needing pre-medication and post-medication, then you might think, hey, if I go to subcutaneous, I may not need these extra medicines. Now, facilitated subcutaneous is a little different because patients can do that some patients do it every 2 weeks, but traditionally a lot of those patients do every 3 or 4 weeks. So it's more like the schedule of an IV medication, but they still are doing it through their fat. And then IVIG, your dose is about every 21 to every 28 days, but we're giving you that large volume. And so patients will see a big shift in their Ig level. So you truly have a peak and a trough, where in subcutaneous, we don't see that. So in subcutaneous, you often have more consistent Ig levels because we're not having the roller coaster. And the other biggest difference is subcutaneous, whether you're doing it traditional or facilitated, you get to doing it in your home on your own schedule. There's no need to go to an infusion center, and there's no need, once you're trained, there's no need to have a nurse come to your home. So if you think, wow, I'd really like to be able to do my infusions in my pajamas on a Thursday night while I watch my favorite TV show, that might be an option. But it's important to know you have an option. Talk to your provider, and together you guys can figure out which option is best for you. And it's really important as providers and as patients, we think about which therapy is right for the patient. Is it 10% right? Is it 16%? Is it 20%? We have options, and that's a beautiful thing. Our patients have options. And if you take 100 patients and ask them, you might come up with 100 different regimens, and that's okay, because it's the beauty of it fits each patient. And then what are the differences between the therapies? What is the difference between IV and subq? What is the difference between the brands? What are they stabilized with? What are the benefits? What are the adverse events? And if this is a child, involve your child. What do you want to do? If it's a spouse, how is this going to affect our family? And look at the financial implications. Is taking that day off of work every month to go get an IV hurting your family financially? Is it impeding your lifestyle? There are a lot of discussions to have and a lot of factors to consider when choosing the right therapy for the patient. So are you down with IVIG? I don't know where I've got this photo, but I've had it for years. So I can't lose it because I couldn't find it again. So IVIG, it's once a month dosing. A lot of patients like that. It's like, I do it once a month. I don't have to think about it again for the rest of the month. That's perfect for me. And patients say, I was feeling bad. I got that one big dose. I feel great again. So it's like, whoo, quickly to feel good. And we can give a large dose pretty quickly. The downside is often you're having to miss time from work or school because you have to do the infusion when a nurse can come to your home, or you can go to infusion center. There are the infusion related reactions and the wear off effect, where patients will say, I know I'm due for my infusion without having to look at the calendar. But as the patient, you get to decide, looking at the pros and the cons of IVIG, do the pros outweigh the cons, and is this the right therapy for you? You have to have venous access. One of the best ways to do that, make sure you're really good hydrated. And I tell my college students, beer does not count as hydration. It does not. Lots of water, and not the morning of. Like, there are those patients going, oh, I gotta go get my IV started in an hour. I better drink. You should have started the day before, at least. So it's really important to make sure really good oral hydration. And then there, we do have the options of infusion ports. In the PI world, we don't really place ports nearly as often anymore because we have the option of subcutaneous, but it is a discussion that you could have with your provider. And then there's some of the risk, and this is one of the reasons, is it's an indwelling device, so you have the risk of an infection. And for our patients who are already at a greater risk for infection, we really, really think hard before we say, okay, we'll give you a port. Medicines, infusion meds. Do you need pre-meds? Do you need post-meds? Are you going to need medicines during the infusion? That's important so you can plan. If you get pre-medicated with Benadryl, you might not be able to drive yourself home from the infusion center. So who's coming to get you? These are things we need to think about as we're planning which route of therapy, which option of therapy is best for you. And then less is best. We want to, and then, we want to look at what medications are you on? If you've always been on this pre-med, but we've never tried you without it, do we need to take a chance and try without it and see, do you still really need it? So that's why it's a lifelong, we're making that collaboration forever, because we're going to see each other frequently to talk about how are you doing? How are your infusions going? What changes do we need to make? Infusion centers. A lot of patients love the social aspect of the infusion center. My patients do. They like that they get breakfast and a game. They get the free gaming, like all of our kids get a gaming console, and they just adore that. And then some patients really like it because there's a nurse right there. There's a provider on hand. So if something goes wrong, someone else is there to help you. Is it close to your house though? We have patients who the closest infusion center is a 3-hour drive. Do you really want to make that 3-hour drive, or could you rather do it at home? Impact on other family members. If you're a mom with small children and you have to take one child to the infusion center, are you going to get home in time to pick your other children up from school? Or what happens when you're missing work every month? The independence of the patient. A lot of patients like their nurse coming to their home. They like to be in their own home, in their own environment, and they're perfectly comfortable with that. But once again, that's the beauty. If IVIG is the option for you, you have choices. It's really important that when we as providers, if we have the choice, we want to pick an agency, especially pharmacy and a home care company that have nurses that are knowledgeable. They know how to do IVIG. They've done this before. Emergency services. This is a big deal. If you live far away and it's going to take an ambulance 60 minutes to get to your house if there's an emergency, doing home IVIG might not be the best option for you. So sometimes there are other factors that play a part in making the decision of which route and which selection of the infusion setting is the most important for you. And it may not be the medicine or the nursing. It may be, can the emergency services get to you if we need them to? And then financial. And this is a big one that a lot of times gets overlooked. So often we don't always get a choice in everything. Sometimes certain payers will say you have to do it at home. Sometimes they say you can do it in the infusion center. But the cost of getting to an infusion center, gas is expensive. Can our patients afford the gas to come? Can they afford to pay for the meals while they're in an infusion center? What about the loss of revenue because they're missing work? Or the concern that my child's going to get behind in school, or me as a college student, I'm going to get behind. So there are a lot of factors that play into it. And these are discussions that providers and patients need to have together so we can pick the right option. And then got to always think of this. We got to prepare for the worst. What if there's an emergency? This is why everyone gets epinephrine. Everybody gets epi in their home if they're on home IVIG. Know your emergency contacts. Keep an updated clinical summary. So if something should happen, you can hand EMS a piece of paper with all of your information on it. And then reactions. So we all know that we can have reactions. Be prepared. Know what to do if there's a reaction. Know who to call. Know how you're going to handle that. And if this is something you can just, if you're home doing home IV, discuss it with your nurse. Should this reaction happen, what are we going to do to make sure you guys have a plan? And discuss it with your provider. So this is just a really old slide on the management of IVIG reactions. It's really old. I think I've had this slide probably close to 20 years, but it breaks it down so simply. And then next, what about subq? So this is where we're going to give it into your fat. We're going to use the syringe driver or an infusion pump. This can be infused more frequently or less frequently to meet the patient's needs. So this is the beauty of it, is we get to pick the regimen that works best for you, and you give it in your home. A nurse will come out, train you how to do it, and then it is self-administered in your home. So those are some of the pros. Is you don't have to have an IV. You don't have to have an IV. That gradual absorption doesn't have the roller coaster effect anymore. And it's really well tolerated. The cons is you have to do it more frequently because we're giving you smaller volumes, and you have to be willing to self-infuse. And most importantly, be compliant. We see this a lot in our college age kids when they go to college and then they go, well, I didn't do my infusion for a month because I got busy. So it's really important as a patient that you be honest with yourself. If you're not going to be able to adhere and do your subcutaneous infusions, maybe staying with IV is the best choice for you. So there's a lot of options. We have 10%, 16, 20, and then the volume will depend on the product and how many sites you're doing. And so that's different per patient. So if you're on product A and you're using 2 sites, and this person's on product B and they're using 5 sites, it's probably a difference in the product and the number and the volume you want. Some patients want less volume in each site so they don't have any bumps. Some patients are like, I want less needle sticks, put the maximum volume in. That's the beauty. It's tailored to meet each patient's needs. So make sure that when you're talking to your provider, you guys talk about that. What is your dose going to be and how many needle sites are you going to need? And most patients do really well. The systemic reactions are much less, but there are the local reactions. They do get better over time, but it's important to know you will get that bump. And then we want to look at it. We want to make sure that the reactions, you're not putting your needles too close together, that you're making sure that you haven't gone in scar tissue. So if you're having issues with your site reactions with your subcutaneous immunoglobulin, talk to your provider, to your home care company, to your specialty pharmacy, so you guys can work together to figure out what is the issue and how to best fix it. And then here's just a quick tool to troubleshoot your site reactions. And then it's really important to talk about what to expect, what's going to happen. So even with facilitated, and that's what patients need to understand, you still get the bumps, you do it less frequently, but the site reactions are the same. You're going to get that pain, you're going to get that swollen area. It's going to get better over time. It's all the same things, whether you're doing traditional or you're doing facilitated. You have to set up the infusion, you have to insert the needles, you have to sit through your infusion, and then you have to look at, how do my site reactions look? How am I doing? And then make sure you know who to call and when to call. So immunoglobulin replacement therapy is a lifelong treatment for the management of primary immune deficiencies, and it is not one size fits all. That's really important for patients to understand. It is not one size fits all. You have a choice, and on only the route of administration, but the product. And IG therapy is not generic. So if you've always been on product A and you're doing so well on it and you've had no problems, and all of a sudden the specialty pharmacy, the home care company, your provider say, I want to switch you to product B, you should say, why? Why are we switching this? I've done really well on this product. What is the reason? And it's okay to ask that question. And it's a conversation that you and your provider should have together before any changes are made to switch your therapy. So remember, you have a choice in your treatment options, and you should be part of the treatment plan discussion. Research shows us that patients that are part of the discussion are more compliant. So make sure you're speaking up for yourself, that you do your research, you talk to your providers, and you say, what are my choices? Let's figure out what works for me. And then it's really important, this last point, and that choice can change as your lifestyle changes. So if right now you're home a lot and you think, you know what, I'm not doing a lot, I want to do IV, the monthly IV works for me, and I'll go to an infusion center, that's great. And then in a year, your lifestyle changes and you're traveling all the time and you're like, I don't want to have to cut my vacation short to come home to get my infusion. That's okay. You can talk to your provider and say, my lifestyle's changed. I want to now change my therapy to fit my current lifestyle. Because remember, this is a lifelong, and our whole entire goal is to find the therapy that best fits your life. Not my life, not the home care nurse's life, not the specialty pharmacist's life, your life. So thank you guys so much.
Thank you, Carla. As always, amazingly wonderful, wonderful information. And at this time, we are going to switch over to the Q&A segment of tonight's forum, where Dr. Duff is going to, I am so proud of you, Carla. Dr. Duff is going to answer questions that everybody has submitted before tonight's forum, during the registration process, and during tonight's forum into the Q&A box. So those questions are going to be asked by my colleague, Colleen Brock, who is Program Manager of Medical Programs at IDF. So Colleen and Dr. Duff, carry on.
Thank you, Kathy. And welcome everybody. It's a pleasure to have you all here this evening, and congratulations again to Dr. Duff. How exciting. So we received quite a few questions before tonight, and we have received quite a few during this evening. So I will apologize right off the top if we do not get to your question, but we will do our best. Dr. Duff, I'm going to start with, we've received a lot of questions with regarding facilitated subq and regular subq. So if you could go into more detail about that, the difference, why you would choose one over the other, all the different parts and parcels to what the difference is between the two of them, that would be great.
Yes, I certainly will. So facilitated subcutaneous, you do another portion first. You do hyaluronidase. So you infuse the hyaluronidase via push method that kind of creates a pocket in your cells, because you're giving, typically with facilitated subcutaneous, you're giving your monthly dose in one subq infusion. So you need to create a pocket in the fat. So you give the hyaluronidase first, and then you infuse the 10% solution. And those infusions, typically patients do them in their abdomen, but you can do them in your thighs. And you do it on an IV pump or with a push pump. And some patients will do it in a bag, some will do it in syringes. There's lots of options. But the biggest difference between traditional subcutaneous and facilitated subcutaneous is the hyaluronidase that you do first with facilitated and the volume. Traditional subcutaneous, we're giving a smaller volume more frequently. With facilitated subcutaneous, we're giving you a large volume at one time. So the way you set it up, doing the pumps is very similar. It's the volume is different and the medication. And with facilitated, you often you do a ramp up. So you start with a small dose, then the next week you do a little larger, then you do a little larger until you get to your full month dose, so that your body has time to adjust to it. And actually, if you go to the IDF website, primeimmune.org, and go under education, there is a whole guide to subcutaneous immunoglobulin that speaks specifically to facilitated subcutaneous versus traditional subcutaneous.
Is there a reason that one would choose a method over the other, or is it just a personal preference?
Sometimes a lot of it is personal preference, where patients want to do subq, but they want to do it once a month. They don't want to have to do it weekly. They don't want to do it more frequently. They like the thought of being able to do subcutaneous in their home, but they don't want to have to do it as frequently as traditional subq. So then this is the best of both worlds. They can do subcutaneous, but they can do it once a month.
What is the time difference between both of them?
So traditional subq, and it depends on the patient. Let me state that, because patients tend to be different. So I have had patients with traditional subq who they get a very small volume and they're done in 10, 15 minutes. And then I've also had patients with traditional subq who like their infusion to go very slow, and they will take an hour and a half or 2 hours. Facilitated, I've had patients do it quickly in like an hour. Some do it in 2 to 3 hours. So
the other question, I'm sure you won't be surprised at, and no one will be, that we're getting a whole lot of is, do you know the status of COVID antibodies in infusions?
I wish somebody would tell me that, because patients ask me all the time. So nothing is official. There is nothing official. So I would suggest for patients to reach out to their specific manufacturer and see with what they know. So I do not want to give any wrong information, and I don't want somebody later to go, but Carla said. So I would suggest, because I know and I'm getting that question a lot from my own patients. When is it going to be in my product, and am I protected? The answer for me right now is I don't know. I mean, I've heard rumors, but I've heard nothing concrete. So I would suggest patients reach out to their specific manufacturer.
And I agree with you. I just recently came back from a conference in Vegas, the IgNS conference, and there it was stated that the research is showing antibodies are in products, but we don't know the level. They're not protective yet, and each lot may vary. So there still are a lot of questions. So even if a patient calls their pharmacy and asks, and they get the runaround, know that what Carla hears and what I'm hearing is that the research is coming. We don't know for sure yet. We do know that there are some in there, we just don't know how much. And right now, there's no research to prove that it's protective.
Nope.
So let's move on to the next question. I have slightly low IgG, IgA, and IgM. I failed the pneumonia vaccine trial. I don't have frequent infections. Is there a reason that I should do IgG therapy if I don't have frequent infections?
So that would be a discussion to have with your provider. Your IgG level, I said the IgG level was low or slightly
Yes,
low?
all three.
Yeah. So the fact that you have low levels does help you qualify for IG. If you're not having infections, then you and your provider can have a discussion. Do you need IG therapy right away? Could you try a different option like prophylactic antibiotics? Not knowing your whole history, and even though you've never had if you're not having frequent infections, have you had severe infections in the past? Do you have bronchiectasis? Do you have other organ involvement? All of those things go into playing a decision, and do you need IG therapy? So I would say, not knowing your history, I would talk to your provider because there might be another option, but IG therapy might be the best option.
Great. What do I do when therapy results in aseptic meningitis?
I'm going to assume, which you know what they say about that, but I'm going to do it anyway, that this patient's on IVIG.
I don't know.
Yeah. So often we see aseptic meningitis with IVIG. And typically when you've had aseptic meningitis with IVIG, one of the things we do is we transition you to subcutaneous. So to do that smaller volume more frequently. There are other treatment options. You can get doses of steroids. You can get steroids before or after. So that would be another thing to talk to your provider about. What are your therapy options if you've had aseptic meningitis?
Perfect. I have a rare blood type B negative. Will that be a problem when I get my first treatment?
It should not. We have patients who have blood types of all types. And since it's the plasma and you're getting the plasma for the antibodies from the plasma, it should not be a factor.
What is our ability to endure IVIG for extended period of years?
So that sounds like, can you take this medicine for many years?
Yes. Like,
Yes.
Is there a cap that you can only take it for so long and then you have to change?
Not that we know of. I have been doing this since 1998. Okay, that makes me sound really old when I say that out loud. So I have been in this field since 1998, and I have had patients who are on IVIG since before I started seeing them who are still on IVIG. So as far as we know, the answer to that question is no. There's no time limit where we go, you've had enough, you can't take anymore.
Great. What is the difference between 10%, 16%, or 20%?
So the 10%, the 16.5, and the 20%, that's the concentration. So the biggest difference, and it doesn't necessarily, so the biggest difference is the volume subcutaneously. How much volume do you have to infuse? So the higher the concentration, a little smaller volume. So the easy math is if you're doing, 10 grams on a 20%, that's 50 mLs. And 100%, I mean, in a 10%, that's 100 mLs, and a 20%, that's 50. And I'd have to do the math for the 16.5, and I'm not doing it right now. So I used to have those numbers memorized too, but I don't anymore. So it's a difference in the volume.
I think I get the picture. What immunoglobulins are we receiving exactly? So let's say I want to travel to a foreign country that requires additional vaccines. Since I don't make antibodies, will I be covered with my infusions? And another question kind of tapped onto that is, if a student wants or somebody wants to go overseas for a period of 6 months or a year and then come home, should they be using a different product? So it's kind of traveling for a short time, are you covered? And then what do you do if you're traveling for a lengthy period of time?
So we receive IG from donors in our own country. So the donors we receive are in our country. So if you're going to Africa, you're not going to be protected against malaria because our donors typically don't have antibodies to malaria. So we would recommend that if you're traveling to a foreign country, as long as it's not a live vaccine, that you get the vaccines that are required to travel. And that would be a conversation to have with your provider, because our therapy is made for people who live in our country. So it does not protect us in other countries from different bacteria, different viruses that are in those countries. So that's a really good question. Don't think, oh, I'm going to go travel to Kenya and I'm protected because I get IG here. You're not protected. So that's a discussion to have is, can I get the vaccines needed to go? And is it safe for me to go? And then for patient, like a student who's going to travel abroad for 6 months or a year, the difference of one, they have a couple of options. If they can get established with a provider in the country they're going to, they could try to get IG in that country. If not, typically what we have to do is they have to take a supply with them and then somebody visits them and brings more, because we cannot ship IG therapy through customs. You can ship it to a military base. That is different, but you cannot ship it. So if a student's going to Spain for 6 months, the specialty pharmacy in the US cannot send them their product in Spain. So if they're on IVIG and they want to stay on IVIG, then the trouble is, can we get them in with a provider in that country who can order IVIG for them? Not necessarily. We can't. So then we say, okay, well, you can transition to subcutaneous and take it with you, and then somebody can you can come home and get some more, or somebody can bring it to you. But again, that's a discussion to have with your provider before you're planning to travel, because that takes some time to set it up. So don't come into clinic and go, hey, next week I'm leaving for Spain for 6 months. Your provider will pull their hair out. Little heads up so we can get it all set up.
Sounds like a plan. Is it okay to use my stomach 1 week and my thighs the next week for subq?
Absolutely, as long as you're using the correct needle size for the site you're using. So if you're one of those people who's lucky enough that your fat distribution is that even and you can use the same size needles in both, great. Otherwise, make sure you're getting one size needle for your thigh and one size needle for your abdomen. But you can absolutely use different sites. That is not a problem.
Perfect. Can you talk about IG replacement in pregnancy?
So I can, because I wrote a paper on that. So a few years ago, I actually did a retrospective study, because we obviously can't enroll pregnant women in research studies. So in the old days, because I'm old, I can say that, we used to say that every patient, regardless when they hit their 3rd trimester, had to have their IG dose increased. Now we know that's not necessarily true. We need to monitor their IG levels. We need to monitor their infections. Not every pregnant woman needs her dose increased, but patients tend to do very well on IG therapy while they are pregnant. Just getting pregnant is not a cause to stop your therapy. Do not stop it. You can continue your therapy. You can continue subcutaneous therapy. And it's a discussion to have with your provider if you're planning on getting pregnant, or you're pregnant, so that you can talk about what is your therapy going to look like during your pregnancy.
Sounds good. How do I know what's a side effect of subq or just my normal symptoms? I have chronic fevers, flu-like symptoms already. So how can I distinguish between the two?
That might be difficult to do, but typically subcutaneous gets absorbed slower. So if like side effects of like joint pain, fever could happen within 24 to 72 hours after your infusion. So if you finished your infusion and 5 days later you're having those symptoms, they're probably not related to your infusion, but I would definitely keep a good diary. Keep a really good diary so you can take it to your provider and say, this is when I infused and this is when my symptoms happened. So you could see if they're correlated.
What are the options for those who do not tolerate IG replacement therapy?
Unfortunately, we don't have a lot of options. And I myself have a patient who has antibodies to IgA, so she doesn't really tolerate IG. One of the things then we do is prophylactic antibiotics. We try to come up with other therapies, but it's very difficult because the IG therapy is the gold standard replacement. There is the gold standard of therapy. So if patient truly does not tolerate any brand of IG therapy, then often it's replacement therapy and doing our best to keep you healthy. But that would definitely be a discussion to have with your providers. Have you tried all of your options for IG therapies?
Going back to the concentration, the person raised, I still don't understand the difference between the concentrations and the volumes. This is all new to me. Can you please break it down and speak slower so that I can understand?
So the concentration is the concentration of product in the volume. So a 10% product to get 10 grams is 100 mLs because it's a 10% product. So 10%, 10 grams is 100 mLs. A 20% product is more concentrated. So there's more antibodies and less volume. So a 20% product, when you get 10 grams, that's only 50 mLs because it's more concentrated. So less volume gives you the same amount of antibodies.
Perfect. How can we explain subq infusions to our specialty pharmacy? I spent a half an hour on the phone with my new specialty pharmacy explaining all about how I do subq infusions at home for 3.5 hours. It's very frustrating. We need more experienced RNs at the specialty pharmacies who truly understand the ins and outs of subq infusions.
I agree. We do need more experienced nurses who really understand subcutaneous. If you're struggling, one of the things I would suggest is asking to speak to the nurse manager or the director of nursing at the specialty pharmacy. Often, and unfortunately, specialty pharmacies and home care companies have a lot of turnover. So the nurses change frequently, and you may be speaking to a nurse who doesn't have a lot of experience. And it is always okay to say, I want to talk to a more experienced nurse. And depending on what you're trying to tell them, if it's a supply question or a pump question or a site reaction question, try to describe it as succinctly as possible. You know, my infusions in the past always took me an hour. I got a new shipment. Now my infusions are taking 3 hours. Something's wrong. Or I've never really had bad site reactions before. I just did an infusion. My site reactions are terrible. Something's wrong. And if they can't understand it, it's also okay to ask for a nurse to come out to your home. They can make a home visit as well.
Perfect. Can antibodies from patients themselves be differentiated from those that they're receiving through their IVIG or even their subq infusions?
So this is one of the big things when you're on IG therapy of whether you're on IV or subq, it doesn't matter. When you're on IG replacement therapy, if you draw an antibody level, you're drawing your donor. So if you want to know what you're doing, you have to draw a PCR. So like Epstein-Barr virus, I'm just going to use that one. If I draw an antibody to Epstein-Barr, I'm drawing your donor. If I want to know if you have Epstein-Barr virus, I have to draw a PCR.
That's good to know.
And it's important because a lot of times if you go to an urgent care or an ER, they draw an antibody titer. I had a patient yesterday panic because her hepatitis came back positive, her hep B, but it was an antibody. It was her donor.
So is it good when patients are having blood work done to make sure that they're not having antibody testing done?
Yes, unless we're drawing antibodies to prove like for children, a lot of times we're proving that they're protected to MMR so they can go to school. So if you need it for that to prove you're protected, then you want an antibody. If we're drawing it to see if you have the illness, you yourself, it needs to be a PCR.
Good to know. Is there any connection with IVIG and anxiety issues? Our son has been getting infusions for 2 years now, and the last 2 months has started having emotional meltdowns. He is 6 years old. Any suggestions?
So there's scientifically, I don't think there's anything that says that there's a correlation between IVIG and anxiety issues. There are some patients who are horribly anxious about their infusions. They're anxious about the needle stick. They're anxious about the medicine. One of the things I would suggest is talking to a behavioral therapist and also seeing if talking about would subq be less anxious for him. But that's also too, depending on the product you're on, you can always talk to a patient advocate and see if other parents have gone through this and what has helped them. For my patients who are really anxious with their IVIG, we try to give them as much control as they can have. Like, which arm do you want us to try first for your IV? Where do you want to sit? Do you want to lay down? What movie do you want to watch? For my patients with subcutaneous, I say, do you want to mark the circle? You want to draw a circle where we're going to put the needle in, or, do you want to put the tape on it? Things like that. So a lot of times giving them some control helps with the anxiety.
We also have at IDF a Get Connected group that is for parents. And that might be a good resource.
That would be a great, because I'm sure other parents have been through this and they can give so much better suggestions than I can.
Earlier in the year, I was told that Medicare will no longer pay for my infusions at my doctor's office. I had to switch to an in-hospital infusion center. Is this accurate information? I now have the choice of just 2 meds at the hospital center.
So some insurance companies do dictate where you can receive your infusion, whether it's in an office, an infusion center, a hospital, or home. So some insurances do definitely dictate that. The other, if you're concerned, you can always call your insurance company and ask, or depending on the product, if your manufacturer has a care line, you can call that line and say, hey, I've been told this, and they will help you figure that out. And if you don't like only having the option of a couple of products, the other option is to try home infusions, where you might have a different product pool to be able to choose from.
Great. I had been getting IVIG for about 6 years. 5 years ago, I had multiple small pulmonary embolisms from my infusions. How common is this? And do you know what causes them? And also, can a person who has had a blood clot in their lung continue to get IVIG? Is that safe?
So we do know that every IG product on the market, regardless of the brand, regardless of the route, every IG product on the market does have a risk of blood clots. We know this, and that's something we look for. That's one of the things we monitor for. So I will tell you, it depends on your provider, but I typically, if a patient has had a blood clot, they don't continue IVIG. I transition them to subcutaneous. Other providers continue on IVIG. It's a matter of monitoring your levels, making sure that you're doing okay. So that would be something I would definitely, if you're concerned, definitely talk to your provider and say, are we monitoring this to make sure I'm doing as well as possible? And or are there any other options for treatment?
Good. Is it possible for a person to need less IVIG over time? After a test, my doctor reduced my subq infusion from 13 grams to 12. We retested. I was still in the normal range and still at the high end. We're going to wait a few months, test again, and see if we need to decrease the dose a little bit again. Is this typical?
So oftentimes, especially if a patient is really sick when we start, or their IgG levels really low, we will dose very high because we want to get that level up quickly. But it can happen. There are patients who, over time, we find that we dose them so high in their level, they're keeping a good level that we can decrease their dose. It does not happen for everyone. More times than not, we're starting off low, so we're increasing the dose rather than we're decreasing it, but it can happen. And that's why we draw levels and we watch the levels and we watch your rate of infections.
Going back to the little boy that's struggling, the mom wrote a little bit more. She said, we're seeing another specialist in St. Louis Children's in a couple of weeks, and they're considering a port. He does have a history of blood infections, so we are concerned. His IVs have been blowing the last several months, and he's been stuck up to 10 times at each visit. Would it be a better route to do subq before a port?
So research has shown us that so if you go to the Quad AI website, which is the American Academy of Allergies, Asthmas, and Immunology, they advise that you try subcutaneous before you try a port, just because the indwelling catheter can be a source of infection. And I would definitely speak to your new provider about those two different options.
Yes. Splenic infarcts, are they a contraindication for either IV or subq infusions?
I'm going to be honest. I don't honestly know the answer to this question, but my thought would be no, because we have patients who have no spleens that do infusions.
Good. I am new to IVIG therapy. I've had 4 infusions to date. I did well, didn't have any side effects. Could side effects develop at any time, or is this a good sign that I won't have any issues as of now?
Unfortunately, they can develop at any time. It is a good sign. So when we do IG studies, we don't pre-medicate for the first 2 infusions. So the fact that you've had 4 is a good sign. But with every lot number, the balance can change of what you're getting because it's so many different donors. So there's always that chance that you may do infusions for years and never have any side effects. And then with one infusion have side effects. So it's hopeful, but it doesn't mean you'll never have side effects. Sorry.
Before every infusion, I have my CBC tested, and every time my red blood cell count, my hemoglobin and hematocrit are always low. Is there a test for why this is happening?
There are other tests that we can do, and I would say you speak to your provider, and your provider may need to refer you actually to a hematologist for more in-depth testing. And the other thing would be is to get a CBC at a different time and see what your numbers are. That may be what we call your normal.
Okay, and going along with that, does the donor affect your blood work results?
So the donor should not affect your CBC results, no. It will affect your antibody results, but it should not affect your CBC results.
Okay. And do you know the ages of people that can donate plasma?
You know, I used to know, and I don't know they have to be a legal adult, so they have to be at least 18. But I don't know if there is a maximum age, to be honest with you. I honestly don't know.
I want to say it's 65.
Okay.
I'm fairly certain. But yes, I know it has to be a minimum of 18. How about I receive subq Hizentra? How much should I be hydrating? And regardless of product, I get a lot of questions about hydration and what exactly does that mean? Because you can overhydrate.
You can.
So what does hydration mean and what type other than beer and wine?
So to actually be hydrated, beer and wine, not so much. And a lot of people don't realize caffeine, it dehydrates you. So if you're drinking coffee all day, you're actually dehydrating yourself. So water, Gatorade, Pedialyte, things like that are really good for hydration. And you want to hydrate to where your urine is a light yellow or it's clear, because then you know you're really well hydrated. With subcutaneous, infusion is not as, hydration is not as critical as it is with IV because we're not getting an IV. So we don't need you, but it also, because subcutaneous is absorbed more slowly and over time, it doesn't have the same effect on the kidneys. So we also want you to be really well hydrated because IVIG is processed through the kidneys. So to keep your kidneys really well and working, you need to be really well hydrated. But it has to be things that hydrate you: water, Pedialyte, Gatorade, not beer, wine, or pop or coffee.
But going by the color of your urine is one of the ways in which to really visually tell whether you're hydrated or not.
Right. So if you get up and your urine is a dark amber, you are definitely dehydrated. Start hydrating until it's clear or very light yellow.
Good to know. Do all of the IVIG products have an emulsifier? I remember my son had IVIG therapy in 2016, which required refrigeration and had no adverse effects. However, he became extremely ill in 2018 with a room temperature product using polysorbate 80.
So all the products have their own stabilizer, and some require refrigeration and some don't. So that's just, it was just, and it may not have been an issue with the specific, it may not have been an issue with the fact it needed to be refrigerated. It may have been a specific issue with that lot number, because there are patients who will have a reaction to a specific lot. And then when you change the lot number, even if you stay on the same product, but change the lot number and they never have a reaction again. So it truly depends on the product if it's going to need refrigeration or not, but they all have a different, they all have their own stabilizer.
Okay. Any suggestions for someone who has PI, MGUS with peripheral neuropathy and MCAS, and is Ig replacement the same for all of it?
So if you have a primary immune deficiency and then you have an autoimmune disease or you have a neurological disease, the dosing may be different depending on the disease you're treating. So immunoglobulin replacement therapy may be the treatment option that's best for all of them, but the dose may be different depending on the disease process you're specifically treating.
And can Ig replacement therapy be used for subset deficiencies?
Like IgG2 deficiency?
Right.
Yes. It cannot be reused for IgA deficiency. We get that question a lot. We don't replace the IgA, so it cannot be used for IgA deficiency.
If you live alone and can only infuse subq on your abdomen where you can reach, but have lots of scar tissue and stretch marks, will I run out of spots by infusing for years in the same general areas each week, just along the midline where the navel is?
You should not, because if you think about it, if you're moving your site just an inch or 2 inches, I'm pointing because this is roughly 2 inches. If you move it frequently enough and you feel to make sure you don't have scar tissue, you should be okay.
Can you talk about the relationship between IVIG and inflammation and how it might help, or if it helps?
So if you have, I don't know what they're like, if you're talking like this, like a lot of patients have inflammation that have CIDP and have other autoimmune disorders, and it does help with the inflammation. But if you're a PI patient that just has joint pain, it may not help with your joint pain. But for patients who have sorry, our dog is making a noise. And I was like, what the heck is that noise? So if you have, autoimmune disease and you're using it specifically for that, it does help with the inflammation. But if you're a primary immune deficient patient who just has run-of-the-mill joint aches, it may not. But we do use it to treat other things, and especially a lot of rheumatological disorders that involve joint issues.
If someone has a lot of allergies, are they more likely to have a reaction to Ig replacement?
I have not seen that correlation, and as far as I know, there is no data suggesting that.
How do donor pools affect your antibodies?
So donors are all tested to make sure. So that's what we test. We bring in it's literally tens of thousands of people to make one little vial of Ig. And so your antibody levels are what their antibody levels are. But we're taking people who have the high antibody levels, who are quote unquote healthy, to give you their healthy antibodies. And typically patients make good antibody levels when they're on Ig therapy. Usually the thing that can affect it is if I've had patients have a reaction to a specific lot. Who knows what was in that lot? Who knows what donor was in that lot, what caused the problem? But if we say don't send that lot anymore, they can continue on therapy and never have another problem. But the changing lot numbers or getting a new vial should not affect the antibodies you're receiving. This should be fairly consistent.
So we talk about the antibodies that we're getting from the donor pools. What exactly are we receiving? This person's due for their tetanus booster, but since they don't make antibodies, they want to be sure they're protected in their infusions, but they're confused as to what exactly are we protected from?
So you should be protected from tetanus. And I always say should, because if I say you are, it's an absolute, and then somebody always wants to prove me wrong. So you should be protected from tetanus. You are definitely getting tetanus. And if you are on Ig therapy, you really do not need to get your vaccines like that, because we're already giving you those products. There are certain vaccines that we recommend people get, like the flu shot, HPV, meningitis, because we don't know the protective levels of those in our therapy yet. But tetanus, diphtheria, MMR, pneumococcal, we know you're protected. And if your provider wants to prove that, they can draw an antibody, a tetanus and diphtheria antibody. And when you have protected levels, then you don't need to get your tetanus booster.
Over time, receiving IVIG or subq treatments, do they start to become less effective in any manner, but this person is specifically asking and preventing patient respiratory infections?
So there's no data to suggest that either. So they don't become less effective. That's why we want to keep your level at a good number, because having that level, that protective IgG level, helps prevent infections. It doesn't mean you won't ever get one, and it doesn't mean you can't develop a new infection, but it does help prevent them. So that's why it's really important to get your Ig consistently to keep that level where it should be.
A follow-up to the antibody questions, this person wants to know, am I protected from shingles? And I know there is conversation about whether a person with PI should get Shingrix. And if so, do they need to stay isolated? Or if somebody in the family gets it, do they have to be isolated? Or how does that whole shingles vaccine thing work?
Right. So we are, because the majority of the population has not had a shingles vaccine, you may not be protected against shingles in your Ig therapy, but the new shingles vaccine is dead. It's not a live vaccine anymore. So most patients with PI can get the shingles vaccine because it is dead now.
Good to know. Do you anticipate a shortage of infusion supplies due to increased vaccines and boosters, as well as a shortage of Ig replacement due to lowered plasma donations?
I hope not. I hope not. We've done very well, knock on wood, through this experience. We've kept our supplies up. Patients haven't had to do without. So I'm going to hope not. We can't ever guarantee, but I'm not anticipating a shortage, no. But if you're concerned, you can always talk to your specific manufacturer as well.
This is the first I have heard that PID patients should get meningitis and HPV vaccines. I am 52 years old. Should I get those?
So I'm sorry, I should have prefaced that with that's usually for for kids. So children get the HPV, and children get meningitis to go to college. So as an adult, you probably do not need those vaccines, but they are now required for most kids. Like at the meningitis, my daughter, it was required for her to live in the dorm. So, and they're both dead vaccines. So that is not, as someone my age, that is not a vaccine I would typically get now, but for children, it is recommended that we give it to them.
Perfect. And it looks like we just have sort of one last question. How can we tell if the COVID vaccines are going to work on those of us with CVID?
So one of the problems with COVID right now is we don't know what is a protective antibody. We can tell you, did you make a response to your vaccine or not? But we don't know what a protective level is. So that's part of the downside right now is we have all of this information, but we don't have a lot of specific information yet. And as science goes on and we learn more, we'll have more specific information. But right now, there is no way to tell if you're going to make a response or you're not. But, talk to your provider about, is the COVID vaccine recommended for you?
Sounds good. Well, Dr. Duff, that just sounds so cool. Thank you so much. And thank you everybody for your excellent questions. I hope we have answered a lot of your concerns, anxieties, questions as to how to start your journey, how to continue your journey, or even how to change your journey along the way, which sometimes happens. So thank you very much for your information. You have been an amazing presenter. And I am going to turn it back over to Kathy to finish it up.
Thank you, Dr. Duff, and thank you, Ms. Brock. Great Q&A session. And thank you to all of our featured sponsors tonight: CSL Behring, Grifols, Takeda, Octapharma, Farming Healthcare, and X4 Pharmaceuticals. Thank you so much. And also thank you to Dr. Duff, who volunteered her time tonight to present. And thank you to each and every one of you who submitted questions and joined us tonight. You made a big difference in sharing information with those great questions, and hope that whether you ask questions or not, you're leaving with some brand new information to help you live your best life. At this time, thank you. Thank you for joining us tonight. Thank you for hanging in there until the bitter end with us. And we hope you found the information helpful. Please remember, IDF is here for you every step of the way. And we look forward to seeing you November 9th when we talk about stress and the holiday season. So good night, take care, stay well.